They're coming.
All right, so, well, thanks for having me. So I'm going to talk about low cardiac output syndrome, and I've put this together from a previous PowerPoint, but so I figured it'd be helpful to have the slides. Some of this stuff can get pretty dense, and so at least now you have handouts, you know, if we don't cover it in enough detail. So what I've got in there for you is an outline, which I'm not really going to go over, but you have it to help guide your way through the slides. But so low cardiac output is this combination between heart failure and shock. And so to talk about it is impossible without talking about the other two. So that's kind of what this talk gets into. I kind of touch on heart failure a little bit, touch on shock a little bit, and kind of see what elements of those two kind of make this low cardiac output syndrome. But to understand it, you kind of have to start at the basics. And, you know, so indulge me for a moment with the boring stuff, the cellular stuff. So as you guys probably all know, an action potential results in depolarization, or just a trigger of a muscle cell, any muscle cell. In the heart in particular, the electrical signal triggers a process of calcium causing more calcium to enter the cell, and that amount of calcium that enters the cell is directly proportionate to the force and the speed that the heart contracts at. And this happens through a couple of different receptor-mediated pathways, and the drugs that you guys use, that we all use in the unit, affect those different pathways. Drugs like, you know, dopamine, epi, milrinone, cyclic AMP, which is also the side end product of one of the pathways, or one of the substances produced, also enhances calcium flow, and so milrinone is something that increases cyclic AMP. And so it helps with contraction and also helps with relaxing blood vessels and so on. So talking more simply about heart failure, the kind of textbook definition is what you have in your handout. So it's inadequate adaptation of the heart muscle cells to increase wall stress in order to maintain cardiac output. And so it's more simply put, just means that the heart is not able to compensate enough to meet the needs of the body. And I don't know if you guys have heard of the Frank-Starling mechanism or those curves, and basically that graphically illustrates kind of what the heart does to try and adapt to increase stress. And so, so when you have a decrease in contractility, for example, in order to maintain stroke volume, the heart kind of stretches out, the pressures inside the heart, the resting pressures and the resting volume goes up. And so those are some terms that you'll hear us talk about when we describe what's going on with certain patients. And so when the heart sort of goes into failure mode, there are lots of mechanisms that kick in to try and preserve function. And so it includes things from the brain, so pathways starting from the neurohormonal axis, and so that includes the sympathetic nervous system. So your adrenals kind of kick into gear. So often, if you guys think about kids that you've seen with myocarditis or really poor function, they often tend to be a bit tachycardic. And it's just because their adrenals have kicked in and they've got higher amounts of circulating catecholamines, so heart's beating a little bit faster, just trying to maintain cardiac output. We all know about the renin, angiotensin, aldosterone system. You guys see us use things like ACE inhibitors to try and modulate that system. And then, not surprisingly, there's also increased release of vasopressin, atrial natriuretic peptide, rate natriuretic peptide, and all of those substances ultimately have the end result of retaining more fluid, so people in heart failure tend to be puffy. But it's to try and maintain circulating volume and maintain cardiac output that way. So really, what's the purpose of the circulatory system? So again, just thinking about things in really simple terms, it's to deliver oxygen to the tissues. And so there are 4 different parts to the circulatory system. So there's preload, afterload. I'm sorry, I'm actually getting into cardiac output. So there's cardiac output, SVR, the delivery of oxygen, and then O2 extraction or consumption. And so when we kind of talk about affecting patient circulation, and again, means to maintain cardiac output, those are the things that we're trying to affect at different levels. And so, and you break down cardiac output, and so that's what I sort of jumped the gun about. You get into preload, afterload, heart rate, and contractility, and fundamentally it really is quite that simple, if you think about all the different drugs that you use and the different tools on the ventilator and things that we try and do to keep our patients steady, especially when they first come out of the OR, that's really all that we're trying to modulate. So the preload is just the initial volume in the ventricle before the heart squirts it out, and that can be affected by so many different things. The total circulating volume, and you guys kind of see us push on livers, you guys do that too. So that's something that affects your preload. We talk often about being intravascularly dry and third spaced, and so your circulating volume isn't always in your blood vessels. It can be within the chest, outside of the chest. It can be within the blood vessels, outside of the blood vessels. We hear about jet, and we often pace patients who are not in sinus rhythm. It's because atrial contraction helps augment cardiac output and augments your preload. It's, again, if you think about it really simply just in terms of what's actually in the ventricle, if you get that atrial kick, what's in the ventricle is a little bit more. Your systemic vascular resistance is, again, simply just all the different resistances downstream that the heart has to pump against. And that, factors that play a role with that are things like blood pressure, the thickness of the ventricle itself, and the pressure within the chest. And I sort of left that intrathoracic pressure thing in there because I'll talk about it a little bit more later when we get into how to manage specific lesions and how we adjust the ventilator. Thing to know about heart rate is that it's the most important way by which neonates augment their cardiac output. So, it's a simple equation, right? So cardiac output equals heart rate times stroke volume. So babies, their hearts are stiff. Like in the fetus, the muscle is quite stiff and it's not very good at relaxing or stretching. And so babies can't augment stroke volume. But the only thing they can do to increase cardiac output is to make their hearts beat faster. And so, again, if you think about your work, it's something that I'm sure all of you guys see all the time. They're hypovolemic, hypotensive, their heart rate speeds up, they're febrile, for example. So low cardiac output is frequently the result of going on bypass, and so I just wanted to point out a few key differences in how babies and infants react to bypass compared to adults. Some of this might be very obvious, and so I'm sorry if it's repetitive, but babies have obviously a smaller circulating blood volume, and so there's a smaller volume of blood that's exposed to all that tubing and artificial materials, so they're much more sensitive to having an inflammatory response. They consume more oxygen. Their PVR is much more reactive. There's intra and extrathoracic shunts, depending on what their anatomy is. Their organ systems are mature, so they're more prone to having low cardiac output and other problems. Their ability to regulate their temperature is really off. And bypass kind of can often trigger this massive coagulation type cascade, and so they shoot off little clots, and babies just don't tolerate that nearly as well as adults do. So baby hearts in particular, as I said, are not as compliant. They don't relax quite as well, but they do seem to do a better job tolerating ischemia compared to adults. Things like glucose are really important, extracellular calcium. Because babies don't have as much calcium stored in their cells, so the calcium outside of cells is particularly something that babies are particularly sensitive to, and you guys see that in effect all the time. They respond like nobody's business to calcium dose. Ventricular hypertrophy and bronchial collateral flow, so it's flow that kind of bypasses the regular circulation within the lungs, affects how the heart does after bypass. Hypothermia, so in order to stop the heart in surgery, kids have to be cooled. Well, people in general have to be cooled, but kids in particular can have some adverse effects in response to hypothermia, and the heart can really be stunned as you try to rewarm it. The solution that surgeons give that they infuse into the heart to stop the heart to actually do the surgery contains low amounts of calcium and high amounts of potassium, which you guys know can be really bad for the heart. And then there's a phenomenon in the operating room that can happen whereby air enters the heart. And so it can happen in up to like 20% of patients. And in about 4% or so, there's no like clinical sequelae, but sometimes you can shoot off like an air embolus into the coronaries, for example, and be really sick. I remember taking care of this little kid who was 3 or 4 years old and had an ASD repair. I mean, how benign is that, right? I mean, compared to all the stuff that we see. That's the kid who should have been out of the ICU the next day, but he proceeded to have a cardiac arrest and ended up on ECMO, which we think was because of an air embolus. In terms of what we do in the ICU after they come out of the OR, it's so important, timely assessment of their oxygen delivery, their oxygen consumption, and their cardiac output is really important for these patients to do well. Fairly low bicarb, high lactates are bad. I put in a couple of bullets about venous oximetry. It's not something that we do here very frequently, but a lot of centers do, like the NEERs. And you may, I feel like, be hearing us talk more about mixed venous sats. I feel like we do that more now than we did when I was here before, but that can be a very sensitive marker of how your heart and organs are doing. So, and it's because when the cardiac output starts to drop, like blood flow starts getting shunted a little differently. So it's all about saving the brain, right? So the body is programmed to take away blood flow from other organs in order to preserve the most important ones, like the brain and the heart. And so venous oximetry can be a way to kind of start to see some of those early warning signs that things are not going well. So typically the sat and the IVC falls first, and then the mixed venous sat drops. It's normal to have a percentage of your circulating oxygen extracted by your tissues and your organs. But if you're extracting more than 50% of what's in your circulating blood, that's a sign that things may not be going so well. So as you guys have seen time and again, there can be this systemic inflammatory response to bypass, which results from just your blood being exposed to all this artificial non-endothelialized material, meaning plastic tubing, stuff that doesn't have endothelium. And that's the way that our bodies are designed, is to treat that as something foreign and to react to it, but that is at the root of what causes a lot of our patients' downfall. And so you can have pulmonary reperfusion injury, myocardial reperfusion injury, massive edema, and you can even have like a DIC type of picture where your coagulation pathways are completely out of whack as well. What people have looked at and found that the magnitude of the severity depends on a few things. So like the sicker you are before the operation, the sicker you tend to be after the operation. The longer you're on bypass, generally the worse that you tend to do. The longer your heart is stopped in the operating room, the more likely you are to have the systemic inflammatory response. And then there's just genetic variations amongst individuals that can cause one person to be much worse off than the other. So some of those systemic responses present as an ARDS type of picture. I talked about increased total body edema, pulmonary edema, coagulation problems, myocardial dysfunction. I mean, this is all stuff that you guys are so familiar with. But what this ends up playing out as is just prolonged time on the ventilator, prolonged need for inotropes. You can have renal dysfunction. This is nothing new to you. This can prevent the chest from being closed in a timely fashion, or right after the operation itself, and it can result in a need for ECMO. Steroids in particular have been well studied and shown to kind of decrease the magnitude of this inflammatory response, and so each surgeon, I kind of feel like, has their own preference for the timing of it and how much they give, but often either the 8 hours prior, 12 hours prior in the OR itself, they'll often give a big dose of steroids to try and temper some of this response. So, kind of stepping back to like the other organ systems that I talked about that played a role in managing heart failure, the body managing heart failure, those can also be affected as a result of bypass. So you have an increase in circulating catecholamines, like epi and norepi. So this is your own body getting so revved up. There's a rise in growth hormone, glucagon. There's abnormalities in thyroid function. So some centers actually do T3 drips in post-bypass babies. So your kidney function is decreased, renal blood flow can be affected. And one really important thing, a pretty large percentage of patients, up to a quarter of patients, can have neurologic injury, and that's particularly seen in babies because their brains are more mature and they're particularly prone to that. I'm going to jump through some stuff about heart failure. And kind of present to you the notion that you'll often hear me say to parents that heart failure has two parts. It's the squeezing and the relaxing. So systolic heart function is inadequate squeeze of the ventricle, and some symptoms that you can see include mental status changes, poor perfusion, decreased pulses, vomiting, poor feeding. But there's also diastolic heart failure, so that's abnormality in the heart to relax and fill with blood in between squeezes. And so that's described as lusitropy, the ability of the heart to relax. And so what that happens is it ends up resulting in decreased ventricular compliance and volumes. And despite increased filling pressures, I should say, it results in that, it's the result of that. So because the ventricle can't relax and stretch, the heart doesn't fill enough, therefore doesn't pump out enough. And so the pressures within the heart start going up, and despite that compensatory mechanism, if that doesn't happen, then the heart can go into complete failure. And so the symptoms of that include like big liver, pulmonary edema, exercise intolerance, which we don't see too much around here, but usually difficulty in feeding is maybe a more practical thing, and shortness of breath. So if decompensated heart failure can then progress to the point of shock, which is complete circulatory failure, meaning that at this point you're not meeting the needs, the O2 and nutrient needs of the body and the tissues. And so what that then means is that normal oxidative metabolism, so using oxygen, can't happen like it needs to, right? Because the cells aren't getting the oxygen that they need. So then they kick into anaerobic metabolism, and lactate is a byproduct of that. And that also results in acidosis, which is something that is so much a part of what we see and do, right? So when we see our kids get acidotic when their cardiac output is low, you note that lactates are going up, and you see everybody freak out. The final common pathway of this, though, is that if you don't treat it, you get breakdown of cell membranes because of the acidosis. It really messes with the electrolytes, causes proteins to not function right. The cell will die, and then ultimately you start seeing organ systems shut down. Now, I'm not going to spend a lot of time talking about the different types of shock, but there are different types of shock, of which cardiogenic is just one type. And so we'll talk a little bit more about cardiogenic shock and the things that can cause your heart to completely fail. So it can be primary pump dysfunction, so something like myocarditis, where the muscle is in and of itself abnormal, and something more common in our adult patients, heart attack. You can have an infarction, ischemia, dilated cardiomyopathy, so again, sick muscles, sepsis, mitral regurgitation, obstruction to flow. Arrhythmias are a major source of cardiac dysfunction, and then shock as well. And then low cardiac output, which is sort of the topic of the conversation, is a cause of shock. But my point is that it's only one element that can result in that process. So the next slide has many symptoms and features of low cardiac output, which I'm not going to list each and every single one. You have it there for you to read at your leisure. But the point of that slide, I guess, is that a lot of those symptoms are very similar to heart failure, and to shock. So again, there's lots of overlap between those three little processes. So you can have signs of decreased perfusion, you can have arrhythmias, you can have EKG changes, big liver, JVD, etc. And the tools that we use to diagnose and manage low cardiac output are similar to the tools that we use to figure out heart failure and shock. And so we do things like chest x-rays, which can show pulmonary edema and like the streaking that goes with that. EKGs can show ST elevation, which we're all kind of wired to look for, but even more subtle things like Q waves and inverted T waves or abnormal T waves, which can be more subtle signs of ischemia. We often get echoes. I wanted to kind of talk about what is it that we're looking for. So we look for systolic problems, diastolic problems. We look for things for mitral regurgitation and tricuspid regurgitation, where, if your left ventricle is doing really poorly, for example, you could have really bad MR as a result. We look at the thickness of the ventricles, thick hypertrophied ventricle, like, one of our other patients has, could be the mechanism behind which that child does poorly. Some of the, and then coronaries, of course, you guys know certain surgeries, we really care about coronary blood flow because it could be affected, so like in our switches or aortic roots and so on. And if echo doesn't give you the answer that you need, then we can do a cardiac cath, which then directly measures the pressures within the different chambers. You can inject dye and get better pictures and try and arrive at an answer that way. I have cardiac MRI on there. We don't do that quite so often, but maybe more so than like our cardiomyopathy patients. Often before they come to the ICU, those are some tests that could be done. So the next slide is maybe much more relevant to you guys, and that's what do we do in the ICU to actually monitor these patients? Why do we look at all these different things? So, so we do look at CBP because it's an indirect way to assess fluid status, but it also can be a marker of how the ventricle's ability to relax is changing. So like if your CBP starts to go up, it tells you that for whatever reason that ventricle is requiring higher pressures to fill. And why is that? Is it tamponade? Is it progression of some kind of ischemic process? Is it valve, regurgitation? But it makes you ask the question. We don't use Swan-Ganz catheters very often here because they don't make them look little enough for most of our little patients, but those catheters, when used, allow you to directly measure some important parameters like your mixed venous stat, your pulmonary artery pressures, your wedge pressures, and so on. We have art lines in most of our patients, which again helps assess things like stroke volume and your cardiac output indirectly via blood pressure, and helps us figure out if we're meeting our goals in terms of supporting the patients adequately. Foleys are actually really important in post-operative management because of urine output, but having urine output tells you the state of the kidneys and organ, and so if your kidneys start slowing down, it tells you that perhaps that blood is getting shunted to something more important than the kidneys because there isn't enough oxygen to go around. And then I have NIRS on there as well, which again, it's another tool that we have for measuring tissue oxygenation and perfusion, and it can correlate with serum lactate mixed venous saturations, and there's studies out there that have kind of shown that.
Priya, we got a couple minutes left.
Oh, okay.
We'll have to go get report, just so you know.
Thanks. All right, I can speed it up a little. And so to manage systolic and diastolic dysfunction, we have a limited armamentarium. So for diastolic dysfunction, there's really not a whole lot of medications out there. You can do things to reduce afterload like nitroglycerin and nitroprusside and milrinone. And that's really about it. With systolic dysfunction, I've got a table in there which has kind of all of the inotropes that we commonly use and what their effects are in terms of receptor function and indications for why we would use it. So I'm not going to go over that. So going to talk briefly about phosphodiesterase inhibitors, so that's medications like milrinone. So milrinone is something that's not chronotropic, so doesn't make the heart beat faster. And therefore isn't pro-arrhythmogenic like a lot of the other drugs that we use, like Dopra and Epi. And it's as such not affected by changes in the adrenal receptors. It decreases both pulmonary and systemic vascular resistance and helps the heart relax and fill better. And so that's its mechanism by which it affects cardiac output. The drug that I have listed below, levosimendan, is something that is used in Europe and may be coming soon to the US, but it's one that we're looking out for because it also, like milrinone, doesn't increase the oxygen consumption of the heart. And then other additive things that we can do in addition to the inotropes are things like vasopressin, steroids, and thyroid hormone. I'm going to skip the bit about the ventilator and how that can affect your cardiac output, but just know that maneuvers on the vent can affect the left heart differently, and you'll see us kind of tweaking the vent based on what the patient's physiology is. I have a couple of slides about just how we manage different lesions. So like in shunted patients, what we're trying to do is manage QP to QS, so like pulmonary versus systemic blood flow, and so often we're trying to decrease systemic resistance to prevent too much pulmonary blood flow. With patients who are Glens and Hemis, often you guys see this, they come out really blue, and so our aim is to try and get them to have passive blood flow from their head and neck, and so we do things with the vent, for example, let their CO2s get a little bit higher, which vasodilates their cerebral blood vessels and helps blood flow to the lungs. With the Fontan operation, you can have low output because of decreased ventricular volume and diastolic dysfunctions. These patients respond really well to volume boluses and to early extubation because that helps passive blood flow into the lungs. TETs are prone to RV dysfunction, and so we have strategies to target that. And just the take-home point from that is just that the RV function can really affect LV function, and so you'll see that particularly in tetralogy patients. And then, if these strategies don't work to reverse low cardiac output, then the options are things like ECMO, which, as you all know, the survival overall for ECMO over many years has been about 50%. Ventricular assist devices, which I feel like we're seeing more and more of, and those have been shown to be a much better bridge to transplantation than ECMO, so we're getting survival in the 80% range in the current era. We can do things like nitric oxide to reduce RV afterload, but that, of course, is only indicated for a select patient population. And then there's this phenomenon called resynchronization therapy, which we don't see that frequently here, and it isn't done that frequently in children, but it's just if different parts of the ventricle are squeezing at different times. They've found in adults that if you actually put in pacemaker leads and force the ventricle for all parts to squeeze together, that actually increases cardiac output. And so there are some case reports of that being done in children with good effects. Again, it's really just select patients that works in. But anyway, so then I just have a little summary slide of everything that we talked about, and which I'm not going to go over since you guys have that and we're out of time probably.